Thank you for joining us today for the American Cancer Society and advocacy affiliate American Cancer Society Cancer Action Network's Fighting for Health Equity Breast Screening Forum. My name is Gina Curry, and I'm honored to serve you as your moderator today. I am so thrilled to be here because this is my very first job, was to coordinate community peer educators to navigate women in the far south side of Chicago that were uninsured to receive mammogram screening. We provided support for barriers such as, access to healthcare. Some of them didn't have insurance. Some of them needed transportation. Some of them they just were afraid and they wanted someone to go with them. Some needed childcare, and all of those things that we provided for them is why this forum today is so important to talk about health equity and breast cancer screening. I'm going to introduce now our interpreters, Griselda Garibay and Emmanuel Zambrino. Once they give a quick intro and give instructions in English and Spanish. Thank you, Griselda and Emmanuel.
Thank you very much, Gina. My name is Emmanuel Zambrano, and I've been part of the ACS family for 10 years now. Really happy to be here and support this great initiative, this great program, much needed, by the way, and as their interpreter in Spanish. So I hope you're doing well. And now I'm going to provide some switch to Spanish so for our Spanish speaking audience connected in the phone line, so they understand a little bit of the rules, the steps, and how the interpretation is going to work. Muy buenas tardes a todos. Les saluda Emmanuel Zambrano, representante de Cancer Control en la Sociedad Americana contra el Cáncer. Muy buenas tardes y bienvenidos. Voy a hacer, junto a mi compañera Griselda, vamos a estar ayudándoles con el servicio de interpretación de la jornada de este foro tan importante en salud de la equidad o equidad en salud con respecto al cáncer de seno. La línea telefónica para aquellas personas que están conectados para poder participar hablando y compartiendo sus preguntas, tienen que marcar la línea telefónica 571-317-3116. 571-317-3116, que está al lado de su pantalla en su pantalla de su computador. El código de acceso para luego que usted marque ese número es el 546-076-933 con el signo numeral. Por favor, silencie su computador u otro dispositivo en el que esté viendo el foro, escuche el audio del foro a través de la línea telefónica y ahora con ello presento a mi compañera Griselda Garibay. Griselda.
Gracias, Emmanuel. Mucho gusto estar aquí con todos ustedes. It's so great to be here with all of you. My name is Griselda Garibay, and I'm lucky enough to be contributing my services in such an important forum. Not only am I part of the Committee for Diversity and Equity, but I'm also now a 5-year cancer survivor. So I'm excited to be here. Un placer estar aquí con todos ustedes. No tan solo soy parte del Comité para crear diversidad con la Sociedad de Cáncer Americana, pero también acabo de cumplir mis 5 años como sobreviviente de cáncer de mama, así que un placer estar aquí con ustedes y por favor no duden en dejarnos saber cómo les podemos ayudar por medio del chat.
Gina, we already provided the instruction to our Spanish speaker audience. With that, I'll pass it back to you.
Thank you, Griselda and Emmanuel. Reducing cancer disparities across the cancer continuum and advancing health equity is an overarching goal of the American Cancer Society and their nonprofit, nonpartisan affiliate, the American Cancer Society Action Network. And I'm so pleased to partner with them on this event as my director at the University of Chicago Comprehensive Cancer Center in their Office of Community Engagement and Cancer Health Equity. We do a lot of things collaboratively to do just this, fighting for health equity. Cancer health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. Convening forums like today's is critical to ACS and ACS Can achieving their 2035 goal of reducing cancer mortality by 40%. Most importantly, as we are all focused on reducing cancer disparities, we all need to listen to the experiences and perspectives of people with breast cancer, their caregivers, and their communities, and engage them in the fight against cancer every step of the way. It will take all of us working together to do this, which is why we are here today. We have an exciting panel of speakers for you who will share their perspectives and insights about the work they do to help eliminate breast cancer disparities and achieve health equity. But before we get started, let's go over some logistics. Today's forum will feature 3 sessions. The first keynote panel will begin shortly, followed by a 15-minute break from 1:15 to 2 p.m. Central Time. There is a community conversation session via Zoom, followed by another 15-minute break. The forum will conclude with an advocacy and policy session from 2:15 to 3 p.m. Central Time. And you can find the Zoom links for both the community conversations and advocacy and policy sessions to the left of the video feed. Below the video feed, you will see the sponsors and partners of today's event. None of our work would be possible without their partnership and support. And we thank you to our sponsors, the University of Illinois Cancer Center, Amita Health, Mercy Medical Center, and VW Credit. And thank you to our partner organizations featured in today's session: University of Chicago Cancer Center, Office of Community Engagement and Cancer Health Equity, Robert H. Lurie Comprehensive Cancer Center of Northwestern University, University of Illinois, Illinois Department of Public Health, Wellness House, Sisters Working It Out, Lucero, and Equal Hope. All participants are muted. However, you do have ways to communicate. At the top to the right of the video feed is a box labeled Ask Our Presenter a Question. This is where you can submit a question for speakers at any time. Be sure to indicate if the question is for a particular speaker, and you want to indicate that in the chat. We will try to get to as many questions as possible. And just below the questions box is the forum agenda and ACS Can facts on our fight information. Please feel free to download and to share. Finally, after today's forum, you will receive a follow-up email from ACS and ACS Can with a link to a survey to provide your feedback on today's event. We encourage everyone to take the survey so that we can continue to find ways to work together in our fight against breast cancer. We really need those evaluations. Now we'd like to play a video for you to help frame our conversation about health equity. Mission moments, and they'll be playing that shortly.
I read a statistic that communities in Chicago, Streeterville and Inglewood, 9 miles apart, but they have a 30-year difference in life expectancy. What is that about?
Unfortunately, there's a lot of research that shows that someone's zip code can be more important than their genetic code.
Health equity, I mean, it's like, okay, what are you saying? There's no equity in health. It's the haves and the have-nots.
Inglewood, 60 years. Streeterville, 90 years.
And that shouldn't be the case. Whether you live in the Gold Coast or the South Side, you should be able to get the same access to care. For most cancers, almost all cancers, African Americans have higher rates of mortality compared to other groups. ACS has always given researchers like me that conduct cancer disparities research and health disparities research a place where we can not just address the immediate cancer disparity, but also address those social determinants that can impact that patient's cancer outcome.
When you can't walk out your door and go have a store that you could get fresh produce. When you can't walk out your door and you have a health issue and the hospitals in your area are closing. It's just behind the 8 ball all the time. That's how you feel. That's how you feel.
You have to share what you go through. Just share it. It'll help so many people.
You have to be an advocate for yourself. You have to know you matter. You have to speak up.
You got to keep fighting.
This is a call to action. We want that life expectancy in Inglewood to go up to 65, 75, 85.
What better looks like to me is that we won't have statistics when we say that African American men are almost 2 times more likely to die from prostate cancer compared to white men. Better looks like the fact that no matter where you live, you'll have access to evidence-based and cutting-edge screening and care. Better for me is when you can get care despite your zip code. I am reminded that we still have a long way to go, but we have made several advances that makes me think that better is on the horizon.
Thank you for that video. Very sobering indeed. However, as Dr. Kareem Watson said, we are doing things to make us think that there is a better on the horizon. I remember when that report first came out, and we actually had a listening session with some community residents from Inglewood when the report came out. And there was, of course, a confusion, like, why does my zip code have to do with my life, with a 30-year gap in life expectancy? And then there was fear, like, what does that mean? They're out to get us again. And then, of course, anger around these statistics in the report. And so we talked to the community about, what does social determinants of health mean? What does it mean? What does equity mean? And, access to quality care. As you heard the young lady in the video said that they're closing hospitals, which was true. They were closing hospitals in the community and even pharmacies. I had never heard the term pharmacy deserts, and there are even pharmacies where Walgreens and CVS were pulling out of certain communities, and the community members were rightly frustrated. But this is why we're here today, because I believe that there is going to be change on the horizon, that we can address these social determinants of health, access to quality care. Do they have a job? Is the education structure intact? Do they have healthy food and fresh fruits and vegetables in their community? Are there transportation barriers? And I think that this is what we're here to talk about today. So thank you again for that video. So now let's get started with our keynote panel. Today we welcome 5 panelists who are increasing access to breast cancer screening and treatment and working to eliminate disparities. Please give a warm welcome to each of our panelists who I invite to introduce themselves and give a brief overview of their work. We have Dr. Pam Ganchow from University of Illinois Cancer Center.
Thank you, Gina. As Gina said, I'm Dr. Pamela Ganchow. I'm the Director of Cancer Prevention and Survivorship at the University of Illinois Cancer Center. And I've also recently taken over as a project director for the IBCCP program at the University of Illinois, where we're becoming a new lead agency for the program. I'm a primary care provider, and I consider myself an onco-generalist, as I have focused much of my work as an internist on cancer screening, cancer prevention, and cancer survivorship, really focusing on improving care at both ends of the spectrum of cancer control, before and after a diagnosis. I spent the last 23 plus years working at Cook County Health, where I spent a lot of my time improving access and adherence to high quality breast cancer screening, ensuring timely follow-up of screen detected abnormalities through navigation and care coordination. And more recently, and for the last probably 10 or 15 years, a major focus of my work has been on building programs and care models that ensure equitable access to risk assessment and cancer genetic services, including family history screening for hereditary cancer syndromes in vulnerable populations. So I just want to thank ACS and everybody here today for inviting me to be part of this panel. I'm really excited to be part of this panel, and thank you. Look forward to our discussion today.
Thank you, Dr. Ganchow. And next, we're going to hear from Paola Torres from University of Illinois Cancer Center.
Thank you, Gina. Hello and good afternoon, everybody. My name is Paola Torres, and I am a community advocate, lead patient navigator, and project coordinator for our My Mammo program at the University of Illinois Cancer Center. And also, as Dr. Ganchow mentioned, we will be having IBCCP at our site, and I will be the community health worker for the program. And both of these programs provide free breast cancer screening services and patient navigation to under-resourced women in Chicago at our Miles Square federally qualified health centers. For the past couple of years, I have also been involved in other projects within the Cancer Center, which include a health systems intervention, where we implemented an evidence-based intervention at one of our Miles Square clinics to increase breast cancer screening rates. I have also provided education and navigation for colorectal screening services, co-facilitated freedom from smoking clinics for community members on the road to staying quit, assisted with the coordination, planning, and facilitation of an annual community navigation toolkit training for community health workers, all of which address health disparities and work on empowering communities with knowledge, expertise, and resources. I'm also a graduate student at the UIC School of Public Health in the Community Health Sciences Division with a concentration in maternal and child's health. Thank you for having me here today.
Thank you, Paola. And next we'll hear from Felicia Curtis, Illinois Department of Public Health.
Hello, everyone. Thank you so much, Gina. I appreciate the welcome, the very warm welcome. I am Felicia Curtis, and I am the Division Chief and Interim Program Director for IVCCP at the Illinois Department of Public Health, Office of Women's Health, where we administer the IVCCP program, the Wise Woman Cardiovascular Program, and the Family Planning Reproductive Health Program, along with the great work that we do in our maternal and child health space. I am under the great leadership of Dr. Ezike and just so proud and thankful for the work that we've done in the space of COVID. Our mission is to engage with the public and to make sure that they are healthy and have consistent access to services and consistent access to resources. And that was really put on display during our COVID-19 response. And so I am really proud of the work that has been done by the Department of Public Health, proud of the partnerships that we've leaned on and enhanced and strengthened to make sure that our citizens were taken care of during this time. And we work in that same vein at the Office of Women's Health and Family Services, where we are proud to be part of the National Breast and Cervical Cancer Early Detection Program and providing these free breast and cervical cancer screenings. Dr. Ganschow, who mentioned that she's now part of our program through the IVCCP expansion, where we added UI Health and we've added Equal Hope. As lead agencies in the Chicagoland area, have worked long time with Paola. So in our health system intervention space, as well as our community navigation space. So I am encouraged to see new faces, meet new people, and just be able to spread the good news about the work that is being done at the Department of Public Health. Thank you.
Thank you, Felicia. Great work. Next, we're going to hear from Dr. Erin Neuschler, University of Illinois College of Medicine.
Thank you so much for that warm welcome. I'm excited to be here. I'll tell you a little bit about myself. I'm an associate professor of radiology here at UI Health at the University of Illinois College of Medicine. I am newer to UIC. I started here in June 2019, but I've been in the breast imaging community here in Chicago for about 12 years. I am currently serving as the Cancer Center liaison between breast imaging and our Cancer Center, and trying to ensure timely diagnosis of those patients who come in for screening. I have a personal interest in screening and additional screening modalities, such as screening breast ultrasound, which I will be discussing a little bit later. And so that's something I will focus on. I am also pretty interested in advocacy. I was the past president of the Chicago Radiological Society last year, and have been very involved with the Illinois Radiologic Society and our breast imaging committee, and talking about breast density. So I'll discuss that a little bit as well. But thank you so much. I'm really excited to be here and be involved in this great panel today. So thank you so much.
Dr. Neuschler, we're excited to have you as well. And last but certainly not least, we have Thelma Razzle from Wellness House.
Hey everyone, thank you, Gina, for the warm welcome. As Gina mentioned, my name is Thelma Razzle. I have a graduate degree in social work, and I'm licensed to practice in the state of Illinois. Currently, I'm a bilingual oncology support and family counselor at Wellness House and a therapist at Creating Space Therapy. At Wellness House, we offer evidence-based psychosocial programs in English and Spanish to support those who have been impacted by cancer. Currently, we offer over 500 programs every month in person and virtually in a range of areas such as individual, child, and family support, nutrition, exercise, stress management, and information and education. As a bilingual oncology support counselor at Wellness House, I focus on helping individuals cope with the emotional demands of cancer, no matter where they find themselves in their cancer journey or if they're a loved one of someone who has been diagnosed. I help individuals process the symptoms of trauma, anxiety, depression, loss, and grief through individual, family, and or couples counseling, support groups, stress management programs. Research indicates that psychosocial support tends to better outcomes from treatment, and so we're here for it. Again, thank you for your time and for being here with us. I am very excited to be a part of this, very grateful. Thank you.
Thank you, Thelma. We are indeed here for it. Thank you all for being here with us today to take a deeper dive into your expertise and scope of work. We will be asking questions of each of the panelists. A friendly reminder to our audience, you can also submit questions for our speakers using the Ask Our Presenter a Question chat box. And again, just a reminder to make sure that if the question is to a specific panelist, to make sure you indicate their name. So let's get started with some Q&A. Dr. Ganchow, I'm going to start off with you. We know that breast cancer disparities are prevalent. Black women are as likely to get mammograms as white women. However, Black women are about 40% more likely to die from breast cancer than white women. What factors can help explain this?
Thanks, Gina. That's a big question. I think we could probably spend an entire day or an entire week really diving into what is contributing to this. And I have about 2 minutes to answer this question. So I'm going to try to provide kind of a broad overview of this. And then I hope that we can keep coming back to this, throughout this session and throughout the day today. I think this is a big focus of today's panels. So, racial disparities in outcomes from breast and other cancers among Black women and Black men are significant, and they really need to be addressed. So when it comes to the data around breast cancer that demonstrates these disparities, it really tells us that Black women are more likely to be diagnosed at a later stage with locally advanced breast cancer and metastatic breast cancers that are much harder to treat. But even when you control for stage, mortality at each and every stage of breast cancer is higher for Black women. And while biologic differences might contribute somewhat to these disparities, for example, triple negative breast cancers are more common in Black women compared with white women and also more common in Hispanic women. Where we see the biggest disparities in survival is actually in the most treatable form of breast cancer. That's hormone receptor positive breast cancer. And why is that? I think we're discovering that, there's many factors that are contributing to this, and it's quite complex. It's not just any one factor. There's biologic factors, there's genetic factors, economic factors, environmental factors, cultural factors, behavioral, psychological, clinical, and social factors that all contribute. Much of the focus to date on these factors has really been on some of the static risk factors that aren't necessarily things that we can change: our race, our family history, the age when we got our period, or when we went into menopause, how many children we have, our income in our neighborhoods that we live in. And I think that's shifting now. And there's a lot of important work that's being done on unmutable, unchangeable factors, and that focus on systemic inequities that we just heard about in that video, and that we've been talking about a lot. And these focus on things like differences in quality of screening and quality of treatment in different healthcare systems, and overcoming barriers to timely diagnosis, and working on ways to improve adherence to treatment, whether this involves better or different treatments, and ways to manage side effects. I think another big, area of focus that we need to pay attention to is increasing minority access to clinical trials, helping us understand how our treatments affect populations differently in terms not only of the benefits, but also the side effects and the tolerabilities. Another major focus now is on utilizing navigators and care coordinators like Paola Torres to better support women through the diagnostic and the treatment process to ensure adherence to timely and high quality care, and address psychological, economic, and other hardships and barriers that really impede access, and then following them throughout survivorship to ensure equal care and equal outcomes. And also improving in communications between patients and their healthcare teams, I think, is also going to be another big focus. I think we're not always, we're missing the mark sometimes and not always meeting our patients where they're at or understanding their questions and their barriers. And so trying to really improve communications between our healthcare teams, not just our healthcare, not just the physicians, but the entire care team, so that patients have access and feel like we're answering their questions and helping them overcome their barriers. So we have a lot of work to do in this area. And I also think we need to start reframing this. So we're not blaming patients for these poor outcomes, but rather working towards system-wide solutions that can help achieve equitable outcomes for all women.
Dr. Canchow, yeah, I totally agree that one of the things we talk about when we're in the community is that it is multifactorial. It's not just one thing. And I'm so happy you mentioned participation in clinical trials, because that's one of the things that my office and many of us here today are, campaigning around to explain and to tell our community constituents about the importance of participation in clinical trials to make sure that these treatments and drugs are generalizable across all of the communities. So thank you so much for that. Next, I'm going to turn to Paola. In your experience, what community-based interventions have worked to increase access to barriers to breast cancer screening? Paola?
Yes, thank you. That's actually a great question, and it branches off from what Dr. Ganshaw mentioned. Patient navigation has proven to assist patients and assist community members in getting that access and education to breast and cervical cancer screenings. And what is also important is creating and fostering the positive relationships with community organizations. And these include faith-based organizations, support groups, consulates, non-for-profits, and any other clinics that are around the Chicagoland area. And these serve to share information and provide any updates within each other for resources that are currently present for breast and cervical cancer screening services. And also including community leaders and members at the table whenever there are any meetings, including discussion about policy work and any other updates that the community members might lean their concerns about, because they are the ones living in these communities and they are the ones that can voice what community members need. And so they really need to be included in these conversations. And having also community members, community health workers out in the community and attending community events and being part of within the community, because by attending events, they're creating a presence and they're being well known within these communities, and they can also talk to other community members and hear what their thoughts are and what their needs are. Another big aspect is creating culturally appropriate breast and cervical cancer screening education material. A lot of the material that is shared within our community may not be comprehensive, and it might not have the information that they need or want, or they might not be able to understand it. One of them is creating it in their appropriate language, and also just making sure that they understand whatever they're reading based on their reading level. All of these are necessary to make sure that they are receiving the resources that they need in a timely manner for breast screening.
Paola, as I mentioned in my opening introduction, one of the first paid jobs that I had was working with community-based, and I don't even know if we call them community health workers back there or navigators, but community-based peer mentors, peer navigators, to help women in the community. And they felt exactly what you just said. They felt so much more comfortable with a person that they saw all the time in the community. They went to church together. Their kids were in Girl Scouts or Boy Scouts or whatever together. And so it really makes a huge difference. So thank you for mentioning that. Now I'm going to throw it over to Felicia. Felicia Curtis, can you please tell us more about the Illinois Breast and Cervical Cancer Program, including eligibility and how to access the program?
Yes, I can. Thank you for asking. I love to talk about IBCCP. We are celebrating 30 years with the National Breast and Cervical Cancer Early Detection Program. And in that 30 years, the Illinois Breast and Cervical Cancer Program has been participating for 26. And so we've been around a long time. And so we're hearing from our partners in the evaluation space at UIC, School of Public Health, that many folks don't know who we are. They don't know about our presence. And And so we want to make sure that we take advantage of forums like this to put that out there. So we are a decentralized grantee of the National Breast and Cervical Cancer Early Detection Program. We have 29 lead agencies that function statewide. We are required to have a statewide presence. So all 102 of our counties are required to have representation. And so we have a lead agency organization, and each lead agency is assigned a coverage area. And within that coverage area, they're assigned a caseload. And that caseload is tied to funding. That's just the reality of our existence. We are a state and federally funded program. And so we are fortunate to have some new agencies join our program in the Chicagoland area. As I said, UI Health and the Equal Hope have joined us. And then we have statewide coverage that includes FQHCs and local health departments and community health centers and hospitals. And so we are thankful for that 26-year partnership. Some have been with us from the beginning. Some of them are new to us. We provide free screening for breast and cervical cancer and diagnostic services and referral to treatment. If you are found to have a cancer in our program, you can be referred to HFS for enrollment in Medicaid. So we are thankful for that component as well to complete the circle there, so to speak, for our clients. For breast cancer screenings, 40 years and older. For cervical cancer screenings, 21 years and older. But for anyone who is found to be at high risk for breast or cervical cancer, they can be enrolled into our program. You have to be an Illinois resident, and we service uninsured and underinsured individuals. And by underinsured, we mean those that have insurance plans that maybe not cover breast or cervical cancer screening or have a high deductible for breast or cervical cancer screening. So we are thankful that CDC has expanded the program over years to allow us to have more outreach. And we're also thankful that the Illinois state has provided appropriation to allow us to have no income requirement for our program. So we are thankful for those opportunities to further expand our outreach and further expand our reach and our capacity. If you want to enroll in our program, we have a 1-888-522-1282. That is our toll-free number that you can call and be referred to a lead agency. That's a very warm and very firm handoff to a lead agency, giving your contact information, and that lead agency has a 24-hour to 48-hour period to reach out to you and get you contacted. And then we cycle back to that lead agency to make sure that referral was made and that enrollment process did happen. We also have a website, www.cancerscreening.illinois.gov, where you can go there as well and get that 1-888 number and be also referred to a lead agency. So we are really lean on those lead agency partners. They are the ones that work in the community, that have those connections with the community at large, and that also provide contracts with our provider network. We have about 2,200 provider network where our clients are then referred and scheduled for screening. And then we have a data system where we keep ongoing track of that individual so they are followed up with and called on a regular basis to get them back into the clinic space for screening.
Thank you so much, Felicia. Very, very important work. You know, I know that, and I'm going to say this just to our audience, that to be sure that when you're in your circles, whatever your, influence, your, spectrum or realm of influence is, to make sure that people know about this very important program. We need as many people that we know that there's need out there. We know that there are people who need this program, even if they're not completely, and Felicia, correct me if I'm wrong, even if they're not completely uninsured, there still is help for them. If they have insurance, maybe they're underinsured and they still need that. One of the things that we do in the work that I do at the University of Chicago is that we work with Chicago State University, and I don't even know, Felicia, if you know this, I have students that one of their projects is to promote the Illinois Breast and Cervical Cancer Program. That is her public health project that she's doing right now, and she's going around to 13 communities on the far south side, making sure that they know about this program and making sure that, some of the lead agencies that you spoke about, like Roseland, which is on the far south side, and Chicago Family Health Center, making sure they know that these are lead agencies, that they can go to them. So we are very supportive of this work, and we are thankful that you're here today.
Yes, and they can access it even if they have insurance. We have Michael Reese that's on the South Side. We have Chicago Family. And so we want you to access those organizations and get enrolled in our program and get into that regular queue and that regular beat of screening. And we do the full continuum. We have our community navigators. We have 11 pilot sites where we are embedding community navigators, and those community navigators are about getting out into their catchment areas at large, finding the resources available there, talking to insurers, talking to employers, social service organizations, to make sure that we build that toolkit as robustly as we can of resources to get to the barrier reduction that you spoke about, Gina. We know that there are many things that compound an individual's health-seeking behaviors. We want to attack those barriers. We want to attack transportation, and we can't fix it all, but we want to know what they are, and we want to put you at a very firm handoff to an organization that can help you address those things so that you can get to your health-seeking behavior. So we want to partner with as many organizations community-wide as we can to make this happen, and we have those community navigators throughout the state, but our intention is to bring them statewide to our 29 lead agencies. But our new ones start with community navigators from the very beginning.
Thank you, Felicia. Now I'm gonna switch it over a little bit to talk to Dr. Erin Neuschler about research. Dr. Neuschler, we know that research shows us that breast cancer risk increases 4 to 6-fold in women with dense breasts, and mammograms miss 42 to 50% of cancers in women with dense breasts. Can you talk more about the role of breast density and what options are in place for women with dense breasts? What questions should they be asking their healthcare providers?
Sure. Thank you so much. And I am a breast imager, so I'm better at showing some images. So you'll have to bear with me while I try to explain breast density a little bit. But so when a radiologist looks at a mammogram, they really are assessing the amount of breast parenchyma there is with regards to normal fat in the breast. So actually in our reports, we actually indicate a patient's breast density. And this really helps when the radiologist says what the breast density is, indicate the extent to which a lesion could be obscured by breast tissue due to overlapping tissue, dense breast tissue. So we have 4 categories. The first is the breasts are almost entirely fatty. So these are the least dense, scattered areas of fibroglandular density. And then we get into 2 greater density, which are the breasts are heterogeneously dense, which may obscure detection of small masses. So this is our wording in the report, as well as the breasts are extremely dense, which lowers the sensitivity of mammography. And previously, we actually used to characterize in our reports the percentage of breast density related to fat. Now it's gone away in our newest, what we call BIRADS manual, and how we describe things in our reports. It's actually a visual estimation on the radiologist, the extent to which a lesion could be obscured. So you basically, with a mammogram, if someone is dense, so either the heterogeneously dense or extremely dense, if we characterize that as the breast density, there is a potential masking effect of breast density. So breast cancers can be obscured. So greater breast density has also been associated with an increased risk of breast cancer at screening alone. But so there is maybe some increased risk associated with breast density, but we also know it's due to the masking effect of the breast density. The level of risk due to breast density alone, it is difficult to assess because it's multifactorial things that affect breast density. So your age, whether you're taking hormones, if you're a breast cancer survivor, if you've had previous radiation therapy or chemotherapy, you've had a child and you breastfed. So there are things that can influence breast density. We do know, though, how the risk from breast density alone is much smaller than age or if you have if the patient has a genetic susceptibility. So really the risk comes with breast density from the potential obscuration of lesions. So just to give a little bit in terms of statistics, approximately 50% of the screening population is going to actually have dense breast tissue. More than half of women younger than 50 fall into this category of having dense breast tissue, and at least 1/3 of women older than 50 years. If you look at the odds of interval breast cancer, so that means between screening mammograms, between someone who has what we call almost entirely fatty breast density and extremely dense at the ends of the spectrum, that's like 17.8 times the risk of breast cancer just due to masking alone. Now, those are the extremes. So usually we're looking at heterogeneously dense, which is sort of our third most dense. And if you compare that between the two categories in the middle, it's about 1.45. So it's much lower risk when you're heterogeneously. So some of the literature, it's important to keep that in mind when we see that big risk. That's between each end of the spectrum. But I just want to talk a little bit about what people should expect in the report and what to discuss with their providers. So 38 states and the District of Columbia have some level of breast density notification after a mammogram. So actually, Illinois was one of the first laws. We had one of the first laws that actually direct women in their report to their breast imaging healthcare provider for more information about the notification. So in the report, if the patient does have increased breast density, there is actually a separate part of the letter that goes to the patient in the mail regarding their results that actually says your mammogram indicates you have dense breast tissue. Dense breast tissue is normal and identified on mammograms in about 50% of women. It can make it more, I'm just paraphrasing, but it can make it more difficult to detect breast cancer on a mammogram and may be associated with increased risk of breast cancer. So what it does go on to talk about is that there are additional screening modalities that we can use in the setting of breast density to help assess for breast cancer. So two of those would be, and I'll just touch on those briefly, I know don't have too much time, but one would be screening breast ultrasound. So there was a large trial called the Akron 666 trial that said that it did include high-risk women, but with increased breast density, that when you added one screening ultrasound to a mammogram, that you revealed 28% more cancers than mammography alone, and that 4.2 additional cancers per 1,000 were detected in women with ultrasound. So it has been proven that screening breast ultrasound, when combined with screening mammography, can find more cancers and is effective. Now, you have cancer people who, believe in screening ultrasound or other modalities, there is a false positive rate associated with screening breast ultrasound. So we may find findings on the screening breast ultrasound that lead to biopsies that are ultimately benign. So we do talk about that there is we can see false positives with screening breast ultrasound. But what's great about screening breast ultrasound, it should be available most places because it's something that we do often in the breast center is ultrasound. It's no radiation. So it's something that can be added. So what I would direct patients to do is if they receive information in their screening letter about that they do have increased breast density, first they can go to their healthcare provider, but we are available as breast imagers to discuss this. So Illinois, again, the first law to say, talk to your breast imaging healthcare provider. It's great because in Illinois, breast ultrasound is covered. The law doesn't indicate necessarily how much insurance has to cover, but it does say a new law in January 2020 actually directed insurance companies to pay for diagnostic mammography, ultrasound, and MRI. Again, per insurance company, and cost sharing may be specific to the insurance company, but it is great that we are in a state that does support extra screening. So I don't know how much time I have. I would like to touch on tomosynthesis for a moment if possible. Gina, do I have time?
I think we have like another minute, sure.
Okay, great. So I just wanted to talk about a technology that's actually been around since 2011. Some of you may have heard we use the term tomosynthesis, but it's a 3D mammogram. It's actually been around since the 1930s, which is hard to believe, but the actual technique. But it really only became a breast imaging tool starting in 2011 when we saw our first approved machine for that. Now, this is not universally available yet. It is becoming the standard of care, and radiology departments are phasing in so that ultimately, I would say probably you would hope in 5 or 10 years that all places are basically what we call tomo equipped or tomosynthesis capable. But it's a little bit different for the patient, not that they will feel anything different because they're actually positioned the same way for the mammogram. It does take a little bit longer, the acquisition, but it's actually low dose x-rays that are done above the patient. So they don't know any different. The gantry goes above them and it acquires usually between 9 and 25 low dose images of the breast. And it's essentially, we can cine through the images. They're 3D as opposed to 2D. Many studies have demonstrated the increased cancer detection rate utilizing what we call digital breast tomosynthesis with digital mammography, reporting between 3.5 and up to sometimes 54% increase in cancer detection. And we actually see fewer false positive recalls. So fewer people are coming back for diagnostic callbacks. And then we're also increasing our cancer detection. So this is a great newer technology that we're seeing being implemented. And in terms of the dose, it is when we do a 2D plus 3D mammogram, there is some dose compared to just a 2D mammogram, but the FDA has now approved to do 3D images only. So again, we'll be seeing that phased in most places as well. Ultimately, usually when a place starts doing tomosynthesis, they will acquire 2D images first to basically have like a baseline for the patient and then go to using 3D. So it really depends on the institution, but it is a great way to hopefully, essentially find more cancers and be more effective. So
those are amazing results. Yes, thank you so much for sharing that piece. And it's surprising that it's been around. Tomo technology has been around since the 1930s, and we're just starting to use it in this way. And you heard me mention earlier. So one of the things that I've been in here. I'm going on to, I say 15 years, but it's actually more like 16 or going to 17 years that I've been working as like a public health practitioner. And so I work with a lot of students. And I have another student that's actually working on a breast density campaign, and we're working with My Density Matters. I would love to talk to you. She's developed a self-guided educational module that we're piloting in the communities to educate women. And I would love to just offline to just, see what you think about it. But we had a listening session, and so many women either didn't know, they had never been, and we have this Illinois law, just like you mentioned just a moment ago. We have a law that says that on your report, it's supposed to let you know if you have dense breasts or not. And the women in the listening session, and this was far South Chicago, so this was Beverly, Morgan Park, Washington Heights. They either didn't know if their status, or they were told that they had dense breasts, but they didn't know what that meant. Right. They didn't know that they had to do a next step. And so is that a provider issue, or because we have this law, and I don't mean to go on a tangent to this because we do need to move on with our other panelists, but they were told that they had dense breast, but not given like a referral to a tomo or an ultrasound or whatever.
So I think that knowledge is everything. So I think one of the things that we try to do, not only does it go in the lay letter to the patient, it also is in the report clearly at the bottom that if someone does have dense breasts, we actually, for that patient, try to recommend what would be best for them. It's obviously we can't order it, but it's up to their referring provider. But let's say they are average risks for breast cancer based upon their family history and they're dense, then screening breast ultrasound is probably a reasonable alternative for them, as an adjunct to screening. Alternatively, if the patient is known by family history to be at what we call a 20 or what we say at least 20% risk, lifetime risk of breast cancer just on their family history alone, they actually qualify to do screening MRI with screening mammogram, and we wouldn't recommend screening ultrasound for those patients. And then other patients that would fall into those are patients who have a known genetic susceptibility themselves, such as like the BRCA gene or within their family. And then I just want to note one newer recommendation from the Society of Breast Imaging and the American College of Radiology are actually in women who are breast cancer survivors, that if they have dense breast tissue and have been diagnosed with breast cancer at any age, we're actually now recommending screening mammogram alternating with screening MRI and not doing screening breast ultrasound. This was in 2018, these were published. And if a woman was diagnosed by the age of 50, regardless of breast density, we are actually also recommending MRI, so screening mammogram with MRI. So what we're trying to do here at UIC is really be pretty specific in our reports. Now, we don't always know the patient's we know their family history because they've filled out a sheet, but we don't know from right now, currently, the way it is, we don't know exactly what their lifetime risk would be calculated to. But if we do see things that in their history that lead us to believe they may, we're going to say, you know, if their lifetime risk is over a certain percentage, consider genetic counseling or high risk assessment. So we're just trying to be directive. And I have even myself, if I see someone that I think does fall in that category and hasn't been getting it, I message their doctor directly sometimes, you know, when it's really, I feel that maybe they should be getting it. We try to be as clear in our reports, but sometimes, you know, it's great to just communicate directly with
Absolutely,
the provider.
yes. Thank you so much. We could talk about this forever because just me in the work that I do with boots on the ground and many on the call as well. We're like boots on the ground. We're working in the communities, talking to the communities. These are the kind of things that come up. So thank you so much for that. I'm going to switch it a little bit now from research and to more community level. So Thelma, what are some of the barriers or needs that are unique to the multicultural communities you serve? And how do you meet needs or address barriers as we navigate the pandemic?
Thank you, Gina. So once you're diagnosed with cancer, immediately death comes to mind. And when you hear the word cancer, even though you know it doesn't necessarily mean death anymore, you can't disassociate. And it's hard to understand the oncology lingo, and everything moves so fast, so things tend to accumulate. And so one continues to balance their own emotions and their own fears and thoughts, and also start to balance their loved ones because they're reacting to this diagnosis as well. And regardless of where one finds themselves in their cancer journey, that fear of death never goes away, because when we're born, we're guaranteed one thing, and that's that we're going to die. But when we're not diagnosed with a chronic illness, we have the privilege to ignore it, push it aside, and say, oh, I'm going to grow old and I'm going to die in bed calmly and peacefully. But that's just not the reality. So once you're diagnosed with cancer, you lose that privilege. And so even though all this stuff is going on in the background and the medical team is working so hard to work and to make sure that you're okay, mentally, you're still struggling with those fears. With those, what if this doesn't work? What if it comes back? Well, who am I now? Because people change, priorities change. Those fears are still there of like, what if I'm not here to see my kids grow or my grandchildren? And those continue to go on, even though, again, the treatment, I hear all the time that treatment is effective and you know, I should be feeling good. I should be happy, but why am I not? Why am I still so anxious? Why am I still feeling so scared? And so that's what we do at Wellness House. We help with navigate a lot of this, but for the Spanish-speaking community, that's not always accessible, because out of 7 or 8 centers like Wellness House in the northern portion of Illinois, we are one of 3 that have Spanish programs. And out of those 3, we're the only one that offer weekly support groups. And so there's a huge need for these communities. And we could say, well, you can go to a community mental health center, but they're so booked. And some individuals don't have insurance or the financial stability to put the money forth for this. And all of our programs at Wellness House are free of charge for anyone, regardless of income status or insurance status. So those are some of the things that we do in our Spanish programs. Are not just directly translated from English to Spanish, but we provide a safe space for individuals to express themselves in their native dialogue without having to be formal and be represented. So we are in tune with the cultural norms, the cultural values and beliefs, so that we are best able to address their clinical psychosocial needs and be able to address that. So some of the ways that we do this is through, we just had Day of the Dead events. Like in our culture, in the Latinx culture, we celebrate Dead of the Dead. What does that mean once you're diagnosed with cancer? What is this now? And so trying to process all of the trauma that has happened from diagnosis to wherever you find yourself, as well as for your loved ones. And I also hear all the time that, they heard about us and they wanted to come, but once they say it out loud, it makes it real. It makes it real and they don't want to, but verbalizing it can be so empowering, and hearing others say it is so empowering. And so once people have come, they're like, if I knew about this and how this was going to help me, I would have done it from the beginning. And so for our communities, or Latinx communities, this is their first time joining a support group or even engaging in counseling. So what we try to do at Wellness House is try to give a little bit of preview. So this month of November, we're going to be launching our Get to Know Us November. So it's kind of like a taste of Chicago style thing, where you get a taste of Wellness House, of the different program areas. So you don't have to feel intimidated and vulnerable to just come out and taste what a support group would be like with this facilitator or this facilitator. What are exercise programs like? Are they good at modifying so that they adapt to where I am physically? What are the stress management, and what works for me and what doesn't? And so we'll be doing that to introduce this to the community. We also provide individual counsel to be able to guide individuals through Zoom and through the technology that is necessary to be able to join a lot of these programs. A lot of them are in person now, but the majority are still virtually offered. And so those are some of the things that we're doing to be able to address some of those barriers.
Thank you so much, Thelma. I don't see any questions in the chat, but I just want to remind, if anyone has questions in the audience, to put them in the chat box. So I'm just going to go ahead and just keep talking here. I think that maybe, let's see, I'm going to go to Paola again. What impact can community health workers have on increasing screening and reducing breast cancer disparities? You talked about it a little bit, but do you want to just go into it a little bit more?
Yes, definitely. And that's an excellent question, because based off on what everybody here has said, their programs, the amazing resources that they offer, and all the education that goes on breast cancer screenings, it translates into what a community health worker does, because the community health worker, or the promotoras de salud, which are known in the community, they are essentially the bridge from the patient or community health member to the actual hospital or provider. And they provide this education to these members in a way that they understand. And they also make the community member feel a little bit more at ease. I don't know about you, but sometimes, you go to the doctor and you're in and out in 15 minutes. Do you really have the time to ask questions that you need? Probably not. Or you may feel nervous, or you may not feel comfortable enough to ask the provider any of these screening services questions. So these community health workers are out there providing you with the education and answering any question in essentially there's no time frame for them to ask these questions. And as I said before, they're easily accessible. And all of the education that they get is, it's needed. And a lot of the questions that these community members have is, when do I actually start these screenings? There's different guidelines that different providers follow. And so we are there to actually give them the information that they need and kind of help them be their own advocate, because at the end of the day, you know your own body, and when you need these services, your own family history. And we educate them on that as well, because a lot of community members don't really talk about what their family has gone through. They may not talk about that with their providers. And so you can guide them into knowing when to start these screenings. And we also help talk to them about, as it was mentioned, there's not a lot of participation in as a citizen scientist, which is when you actually talk about what your community needs. And there's also not a lot of involvement in I'm blanking out on the word now, I'm so sorry. In
Fine.
and Dr. Gancho, you mentioned this before. It was, it'll come back to me. But we need community members to kind of include themselves in these research projects, and so we help guide them and educate them in this sort of way. And then, as it was mentioned before, there's so many programs that exist to access breast cancer screening services for free. And you don't actually have to have insurance. And community members think that this is needed. Or if they have insurance and they have a high deductible, they don't know how to go about not being able to pay for this. And so they might not know how to connect to these programs. And we are the ones going out there and letting them know this is how you apply, this is who you connect to. And it may not be easy for them, it may be easy for us. And so that's why we're there to provide these services for them. And as I said, some of us are embedded in hospitals, some of us are embedded in clinics. And so we have that easy access to communicate with their providers or with other scientists that may help them after diagnosis or with screenings. And so we are that kind of, as I mentioned, that bridge to the hospital systems and easy accessible.
Thank you, Paola. And we are at time. I can't believe, this hour just went by so quickly, but I think I still want to have one just final question for Felicia, because Paola, as you mentioned, a lot of people think they have to have insurance or they're afraid of the high deductible. So I think I want to end on Felicia. Just what opportunities exist for more women to utilize the Illinois Breast and Cervical Cancer Program? And are there other women's health programs that are available? And I think that's a good note to close on, particularly following Paola's comments. We can't hear you.
I apologize, everyone. I had a coughing thing, but I'm better now. I have a cough drop and better. So thank you. But our program is, like I said, we have uninsured and underinsured individuals that can participate in our program, and we have no income requirement. And we have what we call clinically navigated insured individuals. And those are folks that have insurance, but they come to our program and we help them utilize those insurance resources. And we also help them to figure out whether or not if they can or can't meet that deductible. And if they can't, then we step in and help them meet that deductible and get them enrolled and get them moved through for screening services. So we love that we have that aspect of our program where we say there is no open door, there is no closed door. You can come to our program no matter what, if you have public insurance, if you have private insurance, or if you have no insurance. And there is also no income requirement. So we have what we call no closed door, where you can come to our program and we will do our level best to get you into a queue for care. And we have that continuum of care where we go from that community navigator that is front facing and that handoff to that enrollment team, and then that handoff to that nurse navigator if you have an abnormal screen and you're going through that diagnostic process. And then we have that firm handoff to HFS if you are found to have our cancer in our program based on HFS eligibility requirements. So we are very proud of that continuum of care and that access that we have. At the 1-888 number that I mentioned, you can call that number, and that takes you to the Office of Women's Health and Family Services, where you can find out about school health programs. You can find out about our Wise Woman cardiovascular intervention. You can find out about our family planning reproductive health program. And you can also be patched to any of the other programs within our department, whether it's HIV or AIDS programming, whether it's health promotion and cardiovascular health and diabetes programming. We can refer you to those programs within the department. And we can also refer you to other programs within the state network. So we do keep contact and keep tabs with our partners across the state and across the department to make sure that we have current information and can refer you on for additional assistance for whatever programming area that you need. And we work really closely with the school health program as well for adolescent health. And so there are many opportunities and avenues through that 1-888 number to get to additional resources.
Thank you so much, Felicia. Wow. I mean, we are over, and I do apologize for that as the moderator. I should have kept closer time, but this was such a robust conversation, and I'm so thankful to all of the panelists today. Thank you so much to each of you for joining us today and for your tireless efforts to support breast cancer patients and survivors in their communities. We have to move on now. I know we could talk forever. This is such an important conversation, but we've been moving into our break. I think we have about 10 minutes left for the break. And then please come back and join us for the community conversation session. The Zoom link will be found to the left of the video feed. So see everyone soon. And thank you again so much, Dr. Pam Ganchild, Paola Torres, Felicia Curtis, Dr. Erin Neuschler, and Thelma Razzle. Thank you so much for your contributions today. And we'll see you after the break. Thank you.
I'm Whitney Reynolds, and you might know me from The Whitney Reynolds Show that airs nationally, but today we're here to talk about how we can fight the battle against cancer. Tell us about your mother.
She had this saying when we were growing up that we're big, tough girls. Like, you can do anything, you're a big, tough girl. And I've just carried that through like any and everything that I've ever done. And I definitely want to give that to my daughter. You know, like, I really think that's what it means to be kind of like that superhero mom to your kids, being that safe space for them. I just admire that so much. My mom was totally like, that's where I get it from. All of that encouragement came from her.
How was she a hero to you?
She battled with breast cancer for, oh my goodness, I don't even know how many years, since I was in middle school. She wasn't getting the type of care that she wanted where we were living before, so we moved states to Florida, where she got the care that I believe we all deserve, and that made her want to advocate for others. She advocated for herself, so she wanted to advocate for others, and so she got involved with the American Cancer Society.
When you were originally inspired to get into the medical field, is it because of what you saw your mom go through?
Yes, we would think by this point we would have equitable health care for all. And unfortunately, that's not the case. Your race, your zip code sometimes can dictate what type of care you get or the access of care that you receive. It's so just heartbreaking to see that that is something that's still going on. But that's something that the American Cancer Society is working on. There's a lot of research that's being done, different programs that try to bridge that gap.
Do you believe that we will see change when it comes to this?
I do. With all of the different initiatives that they have, all the different campaigns that we have, if we all just do our best, give it our all, it is something that we can definitely do together.
Okay, so this hero campaign is everyday people stepping up. You know, you're one of those. Do you consider yourself a hero?
I mean, that's something really great, right? That we all have the ability to do that, to be super, to be a hero to someone, no matter how small we think it is. Just being there for someone, for example, a cancer patient in their time of need, going to the grocery store, coming over and cleaning their house, doing dishes, something as small as that can really, really, really make a difference for someone. And I love that. I remember that. I remember having those types of heroes in my life growing up, you know? I remember my mom being sick in bed and having one of her friends come over just to check on us kids, just to bring, you know, a pot roast or a casserole, something like that. Can really make a difference for someone.
Anyone can join the fight because cancer does impact us all. But the cool thing is there's no capes or costumes required to do what's right.
And we know what we're fighting for, right? What can we all do as heroes to help attain this goal? For all of us to be on that same mission gives us hope in that way.